JG is a 51-year-old Latino male, presents at Pahoa Bay Clinic on 10/12/2011 at 10:30 a.m. for follow-up for blood pressure monitoring. Condition we are treating today is hypertension. His history of hypertension began years ago and is currently stable. His past medical history includes hypertension, hyperlipidemia, morbid obesity, absence of kidney, BPH. For his family history, his father and mother are both dead. He has 4 brothers, 2 with hypertension, 3 sisters, 1 with hypertension. He has not received too much education. He is currently married. His spouse is alive. He has 1 son, 1 daughter. He is an active Catholic. He is sexually active, drinks 1 cup of coffee per day, drinks a couple drinks of alcohol per month. No reported use of tobacco, marijuana, methamphetamine, or cocaine. He currently works as a cook at a local restaurant. His diet often consists of toast for breakfast, some fruits and vegetables, and salt for lunch. Patient also walks a couple of blocks a day with a hat for sun protection. His hobbies include soccer. As far as patient is aware, his immunization history is up to date. When asked, patient says that his medications are working well with no adverse effect. Patient reports that when he stands up too quickly, he feels a bit dizzy. He also reports that he may be losing weight and his breathing is okay. Patient is 177.8 centimeters tall, 134.71 kilograms, 132/82 for his blood pressure, dropped from a 150/70 from a previous reading. His heart rate is 70, his respiratory rate is 20. His ideal body weight is 69.5. Patient is 94.2% above ideal, and his BMI is 42.7, is morbidly obese. His BEE is 2466.8. His creatinine clearance is 141.42. Patient is ANO times 3, generally appears to be overnourished. No reported signs of hearing or vision impairment. Patient has no canes or other medical supported device. Upon examination, patient has a slight nosebleed, though patient states that it is not bothering him. Appears to be doing very well. Patient makes good eye contact, appears to be comfortable in the clinical setting. Examining his results from past indicates that his weight has been fluctuating over the past several visits, and patient has not, in fact, been losing weight. Pertinent lab values include blood pressure of 132/82, and HDL of 38 from 10/11/2011. Patient has known allergies. Patient is currently on pravastatin 20 milligrams, 1 every day for hyperlipidemia, metoprolol succinate 25 milligrams, 1 twice a day for hypertension, finasteride 5 milligrams, 1 per day for BPH, lisinopril 20 milligrams, 1 every day for hypertension. Risk factors for hypertension. Per HA, risk factors include patients with diabetes or chronic kidney disease with blood pressure greater than 130/80, general patients with blood pressure greater than 140/90, obesity, Framingham risk score of greater than 10%, family history of hypertension, Mexican American ethnicity, high salt diet, metabolic syndrome such as waist circumference greater than 40 inches for men, fasting glucose greater than 110 milligrams per deciliter, triglyceride of greater or equal to 150, HDL less than 40. Of these, the patient has a BP greater than 130/80, obesity, Framingham score greater than 10%, family history of hypertension, Mexican American ethnicity. Patient is Framingham score is 5 with a risk of 14%, vascular age is 64. Patient's current condition for hypertension does require treatment because patient is on medication and his blood pressure is still slightly elevated. His current medication of metoprolol is a beta blocker, but since patient has no CAD, no MI, and does not have heart failure, there's only weak evidence for beneficial effect. This drug may not be proper for this patient per AHA guidelines. Lisinopril can also be a treatment for hypertension. It is an ACE inhibitor that will forestall or treat hypertension and kidney failure when combined with a thiazide diuretic. They also have reduced the incidence of stroke. Patients on ACI show a 22% reduction in composite endpoint CV death, MI, and stroke per AHA. Other drugs for this condition include thiazide diuretics such as chlorthalidone, which is used as first-line treatment due to its efficacy in controlling blood pressure per ALLHAT study. ARBs have been shown with similar efficacy to ACE inhibitors at reducing CV endpoints, though it should not be combined with an ACE inhibitor due to increased adverse effects per the Valiant study. Aldosterone antagonists such as spironolactone show a decrease in systolic and diastolic blood pressure per the Cochrane database. Calcium channel blockers are equivalent to thiazides and ACE inhibitors per ALLHAT. Nitroglycerin are effective but have large adverse effects per AHA. Other therapies include therapeutic lifestyle changes. There are no drugs on this regimen with no indications. Potential interactions include lisinopril and pravastatin, which may cause myopathy and severe hyperkalemia. Metoprolol with pravastatin, which may decrease the plasma concentration in metoprolol. Patient is currently slightly above goal. I'll recommend the addition of a thiazide-like diuretic such as chlorthalidone, 25 mg. Chlorthalidone from the ALLHAT study is one of the most effective treatments for lowering blood pressure and reducing the risk of CHF. Efficacy in reducing blood pressure is increased by the patient's current medication of lisinopril. I also recommend discontinue metoprolol because the patient does not have heart problems nor a history of heart problems, and thiazide diuretics have been shown to be more effective at reducing the risk of hypertension in this group of patients. There's no specific drugs that should be avoided. Tests that will help monitor the patient's condition include blood pressure monitoring. Patient's primary goal is to reduce blood pressure to under 130/80 and maintain it at that level. Secondary goals include to reduce the risk of CHD, reduce blood pressure with some therapeutic lifestyle changes so patient can be controlled better in the long run. Also, reducing the need to take medication from twice a day to once a day will be more convenient for the patient. Side effects that the patient may experience from lisinopril may include acute MI, though it is generally rare. And for chlorthalidone, patient may experience excessive thirst, tiredness, drowsiness, restlessness, muscle pains or cramps, nausea, vomiting, and increased heart rate or pulse. Patient should be monitored for BP, lipids, and fasting blood glucose, which may contribute to the hypertension. Also, patient would monitor for hypokalemia, which may be a result of the chlorthalidone usage. Patient education. Today we are recommending chlorthalidone, a thiazide diuretic, to help you control your blood pressure. This drug will replace your metoprolol, so stop taking metoprolol. You will be taking 25 mg of chlorthalidone by mouth each day. You will also continue taking your lisinopril and other medications. You may take this medication with or without food. If you miss a dose, try to take your medication as soon as possible, but do not double up on a dose. Store your medication in a cool, dry place, so do not keep it in your car where it could get very hot, and do not keep it in the bathroom where it could get very humid after a shower. Those will help you maintain your drug potency. You will not be able to feel the effects of your high blood pressure, so it is important that you get a blood pressure monitor and check your blood pressure regularly, and keep a log of the blood pressure every morning when you wake up. Be sure to use the same arm and bring in a log of your results next time you come into clinic. If your drug is not working, such as you notice that your blood pressure steadily increases, then we can increase the dose of your medication, so switch to something else. Things to look out for lisinopril include developing a cough. And for chlorthalidone, it may cause you to have excessive thirst, make you a little bit tired, drowsy, restless, give you some muscle cramps, nausea, vomiting, or increase your heart rate. As for non-drug treatments, I am also recommending what is called the DASH diet to help you reduce your weight and blood pressure. The goal is to limit your salt intake to less than 1,500 mg, which is about 2 teaspoons per day. Increase your fruits, vegetables, and fiber while reducing your sugars and fats. Many of these you can combine into a meal. You told me you work as a cook, so if you're able to combine these into a meal that you really enjoy, that'd be excellent. You also told me that you like playing soccer, so go out and have fun for half an hour, several times a week. Your diet will go a long way to reducing your blood pressure by as much as 9 points. Also, for every 10 pounds you lose, you can drop your blood pressure by 5 to 10 points. and decrease the chance that you'll get a heart attack by as much as 40%, which is very substantial. I printed a handout from the USDA website showing you how much you can have in each category of meats, fruits, vegetables, sweets, things like that, so you can have an idea of what your food options are. You can also visit the website at www.choosemyplate.gov for more information. Follow up with us in 6 weeks so that we can run a few labs and make sure everything is going well with you. Just to be sure I covered everything, can you go ahead and repeat back to me how you take your medication, what your diet should be, and when I'll be seeing you again?